Hello everyone, my name is Dr. Zafar. I'm a second year internal medicine resident at Mercy Hospital, Fort Smith. Today I will be presenting a case on metastatic head and neck squamous cell carcinoma of unknown primary in a young patient without risk factors. My co-author for this research poster are Dr. Saloni Shirke, Dr. Amita Heiser, and Dr. Daniel Mackey. As we know, head and neck cancer is the 7th leading cause of death with an annual incidence of about 800,000 worldwide, and head and neck squamous cell carcinoma of unknown primary is very rare and accounts only for about 3 to 9% of those cases. In the presence of the known risk factors or symptoms, early detection and treatment of head and neck squamous cell carcinoma is possible. However, in younger patients without any risk factors or any symptoms, just like our patient, the diagnosis of head and neck squamous cell carcinoma can be missed. So let's talk about our patient. He was a 22-year-old male who presented at the PCP office for a routine wellness examination. Patient denied any active complaints. His past medical history was significant for generalized anxiety disorder, eczema, vitamin D deficiency, vitamin B12, and iron deficiency. His family history was positive for hepatocellular carcinoma in his paternal grandmother. He denied any history of smoking, alcohol, or illicit drug use. He was not sexually active and denied any recent illnesses as well. Physical examination was performed, which revealed 2 enlarged lymph nodes palpable in the right submandibular region and 1 very firm non-tender lymph node along the right sternocleidomastoid muscle. Ultrasound of the neck showed multiple enlarged level 1, 2, and 3 lymph nodes, with the largest measuring about 3 cm in size. Due to suspicion for underlying malignancy, a fine needle biopsy was performed, as evident from figure 1, 2, and 3, which revealed nests of polygonal cells surrounded by mixed inflammatory infiltrates, epithelioid cells with enlarged nuclei, and scattered mitotic figures. Patient's histopathology was positive for P40 and cytokeratin AE1, AE3, as evident from figure 3. A PET scan was also performed, which revealed increased uptake in the 4 right cervical lymph nodes at level 1, 2, and 3, with the largest measuring about 20 mm in size. Direct diagnostic laryngoscopy and nasal endoscopy with blind biopsies were non-revealing. The patient was then diagnosed with stage 4 head and neck squamous cell carcinoma of unknown primary. He had empiric bilateral tonsillectomy at that time and received 3 cycles of doxycycline, cisplatin, and fluorouracil, followed by 6 cycles of weekly cisplatin with concurrent radiation. Patient did well post-treatment and is currently in remission with no disease recurrence and doing well. So let's discuss a little bit about head and neck squamous cell carcinoma in detail. Head and neck squamous cell carcinoma is associated with heterogeneous group of risk factors, which could be viral, non-viral, or other etiologies. Viral-associated head and neck squamous cell carcinoma occurs in younger adults, with the main culprit being human papilloma virus, Epstein-Barr virus, and human immunodeficiency virus, commonly known as HIV virus. Non-viral associated head and neck squamous cell carcinoma tend to occur more commonly in older adults, with tobacco and alcohol being the most common risk factor and having a dose-dependent effect on head and neck squamous cell carcinoma. Other less common etiologies include slaked lime, opium use, air pollution, immunosuppressed traits, poor oral health, occupational exposure, nitrites, and sometimes certain genetic polymorphisms. Now that we have discussed about various etiologies contributing to head and neck squamous cell carcinoma, let's discuss a little bit about the prognosis. The 5-year survival rate of head and neck squamous cell carcinoma is less than 50%. Locally advanced disease has a recurrence rate of approximately 15 to 40%, which is mainly due to the delayed diagnosis at advanced stages when the risk of recurrence as well as the metastasis are higher. Most importantly, one thing we should be keeping in mind is that determining the primary tumor site positively impacts the survival outcomes through targeted therapeutic interventions in patients with head and neck squamous cell carcinoma. A comprehensive clinical history, thorough physical examination, and appropriate imaging modalities, including hybrid imaging, are crucial for localizing the primary site. In cases where the occult lesion remains elusive, alternate diagnostic approaches such as pan-endoscopy with blind biopsies, transoral robotic surgeries, and transoral laser microsurgery can be utilized, offering the advantage of therapeutic benefits with the later interventions. Thank you for listening.